systems, and the specific focus is how to refer patients to KNH. My name is Amina Gulid. My work here in Kenyatta is the head of UHC and Universal Outreaches. And one of the key details that as UHC in Kenyatta we focus on is making the referral systems better and to connect specifically for now public hospitals better, but including private hospitals as well. But we can only start somewhere, and our biggest challenge is to start with the public hospital as we proceed with all hospitals. I wanted to start with a general overview of all the public hospitals with a specific focus on level 5 and 4. Where I got the source of data is the Kenya Master Plan. It's usually online and you can quickly see all the health facilities available in the country. It gives you the code and the sub-location where they are. And from there, we had a total of almost 325 public hospitals in level 4. This data has not yet been updated because there's a lot of changes that have happened, but I'm going to use the data as it is. And from all the counties, as you can see, Kisumu, not all counties have, from the data, it shows that not all counties had level 4 facilities. The counties on our left of the screen is the one that usually has level 4, and Kisumu had a bigger number. The percentage was a bit bigger than the rest of the counties, while others had 1 or 2. So that's why the counties are shown as below. Then on our left side is the level 5 hospitals. The distribution really is about in 10 counties where we have level 5. And as you can see here, Kiambu is the one that actually has 2 level 5 hospitals, which is very interesting because Nairobi does not actually have a level 5 hospital, which I found to be extremely interesting. And it's very few counties that have this, but from discussions I've had with several stakeholders, I hear it's an upgrade for Mombasa, Meru, and if I'm not wrong, Kisii County to be level 6 hospitals, while they upgrade the other hospitals to level 5. For level 6 hospitals, which are the apex really of most hospitals in Kenya, that's how our Kenya, the way it has been structured. We have levels level 1, 2, 3, 4, up to 6. We only have 6 registered level 6 hospitals in the country. Amongst them is Kenyatta National Hospital, and of course Mathare National Spine, KU, KNH-UoN, and Moi Teaching and Referral Hospital. So, and I believe also Mama Margaret has joined into the list of also being a level 6 hospital. But as I said, the list, I did not want to update it unless the master plan has been updated. So I will wait for the master plan to be updated. But from the observation, the small observation, you can quickly tell that Mathare is purely mental. The reason why it has been classified as a level 6 is the concentration it has on mental health. We have very few mental health hospitals in the country, and Mathare has been tasked to do a lot in mental health space. However, they still see outpatients. They have a level 3 or 4, which they see patients on a day-to-day operations, but the level 6 part is purely the mental. And National Spine, which is located in Upper Hill, is specifically for spinal injury patients. KU Teaching and Referral Hospital, it's located in Nairobi as well, but it's near bordering Kiambu County, whereby the good thing, it's the same as Kenyatta and Moi Teaching, where you have almost all specialities in the hospital. But of course, we are all limited. We don't have, our focus is actually to have most subspecialties in the hospital. Next slide is to talk and expound more on what Kenyatta National Hospital is. So we are officially 121 years old now. We started off as a 40-bed capacity as King George. Back in the days, there used to be a lot of segregation, whereby you'd have black and Asian and African. But at the moment, we have integrated and we have expanded up to 2,000 beds. However, this data is changing because we also have annexes. As you have seen, KNH-UoN is one of our annexes. It has about 350 beds. 300 beds, and out of the 300 there's almost 20 ICU beds that are now almost, I believe they're fully operational now, to be, and it's visioned to be our center of excellence for non-communicable diseases. Then also we have Mama Margaret Uhuru Hospital, who currently is being led by Dr. Robai, who is moderating the session right now. It is located in Korogosho, whereby it has a bed capacity of 350, and the focus there is really pediatric, especially tropical diseases, but it's in summary something like that. So Kenyatta has almost over 6,000 staff, but if I'm also to include Mama Margaret and Othai, of course, it is so much more. And I thought it was good for me to be more specific on the specialists we have. We have over 200 medical specialists spread across the distribution list as shown on the image. We have anesthetist, and in the specialized surgery, that's where we have the plastic surgeons, pediatric surgeons, psychotherapy surgeons. And in medicine, we have many subspecialties, amongst them being endocrinology, rheumatology, and all of those other medical specialties. Reproductive health, we have different specialties in them, and we're building capacity to even fetal medicine at the moment. So, and infertility, we're having an infertility, we are almost setting up for an infertility center in line with our vision to be a world-class center for specialized services. So our focus is really to have specialized services, and the hospital has driven the agenda to actually build more capacity, especially in subspecialty trainings. So unfortunately, I did not do that data analysis for all the subspecialties in the hospital, but we have very unique subspecialties, amongst them being like plastic surgery. You'd have a person specialized in microscopy surgery for plastic surgery, who, if I'm not wrong, is the only one available in the country. So our outpatient statistics is roughly a daily average of 1,000 to 1,500 across all clinics, and our inpatient capacity is up to 70,000 full bed capacity annually. Our entry points, that is a summary of our entry points. It's Kenyatta, I don't know, for anybody who's been to Kenyatta, you would know that Kenyatta is a very huge facility. So it's good to map out all the entry areas whereby patients are actually entering the hospital. So we have the pediatric emergency center. It's located in the clinic area, whereby it's an emergency center, and our capacity is actually up to 4 critical babies. But of course, the turnaround time is quite high, so they're able to take the patients to the appropriate ward or ICU as need be. Then we have our accident and emergency here, the critical patients. I just took that as a parameter. The capacity is actually more, but for the critical patients, we can handle 10 critical patients at any given time who can be either intubated or on observation on a monitor, stuck to a monitor. For NBU, we have a 5-bed NICU capacity with a nursery. For pediatric ICU, usually we have a 5-bed capacity. This one, people do not use it as an emergency. We normally use bookings as opposed to emergency because it's subject to availability. And as you can see, the bed capacity is quite small in the main hospital. The statistics, by the way, is only for the main hospital for now. And the main CCU has a bed capacity of 21. Also, we do bookings, and probably I will explain later on how best to go about it. Then we also have the medical CCU, obstetric CCU, and the reason why I have segregated them is because of the need for people to understand that we have for better focus, we have different CCUs, and I've actually not mentioned all. I've only mentioned the ones that a patient can go directly to. The reason why we have this CCUs is to have a specific group specialized to focus on that particular area, and for also that specific illness or vulnerable group not to miss out. So you find that the main CCU is the only CCU that can take all patients, but at the moment the way it's structured, it's mostly for surgical patients, and at times when you walk in, you find that majority of the beds are actually pediatric. So in as much as you're seeing 10 for children, really in reality they are spread across, and they can go to main CCU, and you can find half of the main CCU is actually children. And I thought that was a good thing to mention. Then we have labor ward. Labor ward is an emergency. It's an emergency entry point whereby a patient can just fully go and go in. The capacity, of course, like I said, this is for critical care. Sorry, I did not specify it there, but they can be able to take care of 10 critical women at any given time. Then we have another entry area, which is the elective specialized clinic. This one, they're elective, and we have approximately 70, but I don't know, I've written 60 here, whereby we see different patients at a specific time. Each clinic has a scheduled time, but there are those clinics that are run through. One of them is the CTC, which works from CTC, meaning Cancer Treatment Center, which works all through the week, from Monday to Thursday, where they see new patients and they just do reviews on Friday. And we've also partnered with Nakuru County, where they have also started having radio oncology sessions, where some team members visit Nakuru to see patients and to have that mentorship building capacity, which is one of the key areas in my unit. Then there are those primary care clinics like ENT, ophthalmology, CCC, rehabilitative services, meaning occupational therapy, physiotherapy, which are usually a walk-in, and they're usually in specific locations, and you don't need a referral note for this specific clinics, and they're just open from Monday to Friday, and of course public holidays that would be there. So another key area that we want to look into is ward transfers. Sometimes you would have a patient admitted in another facility, and it does not make sense for them to come to an emergency center. So ideally, they should have that. We are trying to practice in a model of ward to ward transfers. Like somebody is in Machakos or they're in Kiambu, they come to Kenyatta. Then for lab, currently we have almost 13 labs, and they are all ISO certified. And for the last 2 years, the lab team has been very, very keen in making sure we have almost all running labs to be a sense of excellence and to have very unique understanding. So we have different MOUs with different counties, even as a can. Sometimes we do that exchange, but of note is the HLA lab. It's the only lab available in East Africa, whereby they normally do organ-to-organ testing to see if you're compatible, and it's cost-effective. I know 59,000 might seem a lot, but usually for somebody who's doing donor testing, they would know that it's actually offered at a subsidized rate, and sometimes we actually offer it at a further subsidized rate when we're having our outreaches. Then we have MRIs and CT scans. So you would find that some specific illnesses would require the specific MRI we have, because we have a 3.5 Tesla in the hospital. We have a bigger capacity to check some specific illnesses, especially cardiac. So we are working on a framework whereby we can have better referral systems, such that you don't need to be in the clinics, or you don't need to be a patient in Kenyatta, you can just go to lab directly and radiology directly and go back to see your specialty, your specialist. So I like clustering things, and how I cluster referrals, as you have seen, is emergency and elective referrals. So emergency referrals, I think I've mentioned all the entry points, and they are quite clear, and they all have different hotlines. So as on my left is one of the posters that we had worked on. Apologies, I'm supposed to change one specific number for people, but all the other numbers are actually KNH numbers, and they are all active. And if you want to have an adult emergency referral, that is the hotline you call. And if you want to have a pediatric hotline referral, this is the number to call. If you want to have a labor ward referral, this is the hotline to call. And when you want to transfer a newborn, this is the number to call. And if you have a pediatric who has who needs ICU or also renal dialysis, this is not the number to call. I am to correct this. Apologies for that. But regardless, I thought it's important for us to have to know that there are specific numbers. I think that's the key take-home message, is that there are specific numbers to actually address this. And for IDU COVID, that's the number. Then for the critical care, like I said, there were bookings. This one you just call the normal exchange line and this exchange line can really take you to any place in Kenyatta. But I thought it was important for me to say that. So you call exchange and you say, I want main CCU. Those are the terms our telecommunication team have been trained to divert calls to those specific areas, so that they can be able to capture that. Another thing that I thought it's very important for us to talk about is we have a dedicated email for complaints and compliments, or any query really for referrals. So this email is purely dedicated for that. In case you have any queries or you want to have any elaborations, you can use this email to ask. Even a complaint like we didn't speak nicely, or we frustrated a patient, or we were good to the patient as well. I'm sorry, I got complaints, but regardless, those are the things. And I hope you would write the challenges you face when you refer an emergency patient to Kenyatta on the Q&A session. So the next one, I just picked a sample of one of the clinics, which is GOPC, is actually elective referrals. Like I mentioned earlier, there are over 70 clinics in Kenyatta. And what you need to have, I'm sure you've had, Kenyatta, you cannot come without a referral note. So yes, you do need a referral letter. The referral letter does not have to be written by a KNH employee, as long as you are referring to the right clinic. And maybe in our later sessions, or even we would make this schedule available on our platform. Although in some of it is available, we will make it quite clear so that everybody can understand when the clinic is. So one of the things that you need to have for an elective specialized referral is I will pick infertility clinic. We normally have infertility clinics on Monday. So what this means is kindly, when you're sending the patients to Kenyatta, you are supposed to send that specific patient in on Monday, as opposed to sending them on Wednesday, because we do not have that session on that particular day. So at times, but infertility is not a very cumbersome clinic. It may not be the best example, but for instance, neurosurgical clinic, if you say you're coming on Monday afternoon to the neurosurgical clinic, you would have to give the referral note. There's a consultant there who will review the referral note. So I am also advocating for better referral notes from the referring facilities, so that you communicate better with the doctor, because they will not see the patients, they will just go through the referral notes, and based on the referral notes, they will advise. If they feel like the patient needs to be seen right now, they will see the patient right now. If they feel like this patient even requires to go to the A&D department, they will refer the patient to the A&D department. And if they feel like this patient, because there's a long queue, maybe in that particular clinic, they will refer the patients to come on a specific date. So of course, like any other thing, we have our challenges. And like I said, please, if you have any challenges that you probably want to ask, please post it on the Q&A so that we can answer that after the presentation. Then this particular picture is a picture whereby we had a training for specifically triage. We had adopted we had partnered with Emergency Medicine Kenya Foundation to train over 10 facilities, and each facility had 2 members. So you would have different members sitting in and listening in and learning. It's a 1-day training. We had it for 3 days, so we trained 60 personnel on triage systems. So earlier on, we had a committee, a setup committee comprising of almost all the entry points in our facilities, so that we can get feedback from the referring facilities that we visited, which is namely Machakos, Thika, Kiambu, the surrounding one, Mama Lucy, Magati, and of course Isiolo and Samburu team. They've been coming, and we've also been going to their facilities. So one of the biggest gap, the emergency points we had noticed, is we don't have a unified entry. We don't have a unified triad system. Everybody is using different triad systems, and I thought it was very, or rather we thought as a committee, it was very key for us to have a better, efficient referral system if we all spoke the same language, and the same language would translate to a triad system. So the triad system at that particular point was a Canadian triad system, but it has been overtaken by VoIMS, whereby we are having WHO. They had released one, and for sustainability purposes, as a team, we think it is best if we adopt the WHO one. So we're in the process of implementing it in our own facilities, and also we would advocate for the other referral facilities to do the same, to make our communications better, and to make our, you know, like if I say I have an emergency patient, we all know what emergency patient is because we're using the same triad system. If I say we have an urgent patient, they're all speaking the same language. So I hope that works, and I hope the implementation this year can take part, and you can leave your comments or your questions on the Q&A. So the last part that I wanted to talk about was innovations in terms of referral systems. So whenever our key focus is really to be a patient-centered society, whereby we try our best to make sure we communicate very well with the patients, and one of the things we want to look at innovative ways of actually making these things better. So telemedicine comes as an opportunity to improve specifically our elective referrals, meaning that what we can do is you can book the schedule if we have a good layout and framework with the referring facilities, which are the level 5 hospitals, whereby a patient can be given a referral letter and actually book a telemedicine consult and be seen during the clinic times. And I think it's ideal, both as filtering, as review, and also as follow-up, so that the patients can come in later. We piloted with Isiolo County, although we've had very few sessions with them. They have been extremely impactful. One of them is a child, a 13-year-old child, who for 7 years, he had been in the lower part of Isiolo, and we managed to get a urology consult and pediatric nephrology consult via telemedicine, and the baby was actually eventually came to Kenyatta, but he came with a clear roadmap and had a biopsy and was diagnosed, and still on follow-up. So the impact is big and the potential is bigger, but the logistics of it is what we as KNH are working on, making the logistics more easier. And this platform is actually the best place for us to have those brainstorming ideas while we're doing that. And a system is the best way to do it. So as a hospital, we developed a system which we are trying to pilot with our own hospitals, meaning Mama Margaret and Kenyatta Othaya, it's actually Moi Kibaki Hospital, and the ministry is also has developed rather. It's still under development, but it's always having new things. Digital health platform, which one of these days I will invite Dr. CKNA to give a brief on what the digital health platform is. They're piloting with 7 hospitals, Othaya being one of them, and one of the modules is the referring components, because one of the biggest gaps is we do not have the same systems. That's why it's extremely hard for us, or we don't have systems which are integratable or communicating with each other. So there's a module whereby you can share that information of the patient when referring the patient, and such that you don't have to repeat a lot of things, and you can actually see who's coming and you can plan better. So also, I forgot to put it on the slides, is some of our groups also reach out. We reach out, and we also want people to reach out to us. That's why we've put the specific slide on where to address us, and you have our hotline where you can, the hotlines is not really for complaints. I would advocate for you to put your complaint in the referral email, but really we want feedback. We value feedback. The only way we can get better is if we make each other better by giving ourselves constructive criticism, as opposed to just giving somebody a problem without necessarily a solution. So without much further ado, I think I will stop there so that we can listen to the different questions and address them. Thank you very much, and I hope it has been informative, and looking forward to having you. Provide. Okay, I can't get all the provide, so I would go for the answer and questions and answer session. Let me stop sharing. So Ruth is asking, I support women in informal settlements for pain screening for cervical cancer, while they refer them for further evaluation. For example, I'm sorry. So you want to know where to refer patients who have for suspicion of cancer? Yeah, like I mentioned earlier on, as long as you write a referral note, you can send them to the gynae oncology clinic number 18. And like I said earlier, I will share the schedule with the marketing team to post it on our website so that you can have a clearer picture on that. What are the likely charges in order to prepare financially? The charges for the hospital, I believe we will put all this information. I don't want to misquote the hospital, so we will put all this information on our website for it to be easier for people to have. Referring a pediatric patient who needs mechanical ventilation has got to be the most difficult referral to make. The response is always that there is no vent available. So, Stephen, one of the things that I can advise is we have our own challenges at the hospital. but we are trying to overcome the challenges by communicating clearer to the people who are referring patients. So like I said, there's a hotline specific for the pediatric ICU, but there's also a hotline specifically for any ICU. So you can try both lines, and you can also try the A&D department. But I agree with you, referring any pediatric patient who requires mechanical ventilation, even within the hospital itself, is extremely, extremely difficult because of the capacity. So probably we can build that. Ruth, we have not yet come to conclusion on how much the telemedicine is. The pilot project that we had with the Isiolo County was actually sponsored, so we did not have like a cost, but we are hoping NHIS can offer telemedicine services to the public hospital. We are in discussion for that. Please to hear Dr. Robert, I don't know if you're around. I feel like I'm talking to myself. Can one refer patients from a private institution? Like I said earlier, yes, people can refer patients from a private institution to Senior International Hospital, but however, we still go with the lines of the referral and how the government has specified how referral should happen. However, there are those patients who can come directly, like transplant patients can come directly, cardiothoracic patients can come directly to the hospital without necessarily going to a lower level hospital. Can one send patients for imaging to be done using NHIS? Yes, as long as it has been requested by a medical doctor and the form has been signed, yes, they can be sent for imaging using NHIS. However, NHIS only covers CT scan and MRI, and I think in the new contract, they also accept specialized ultrasound, which Doppler is actually on account. So most of the others are actually always not by the ICU, how is being addressing that. So as a hospital, like I mentioned earlier on, we have our limitations, and our limitations are we have only about 86 ICU beds, and to be honest with you, I think we are the ones with the most of ICU beds. We have overstretched ourselves, and we have also built capacity in our annex, whereby Obaya currently has almost 20 beds. Meaning, if you're to actually, and hopefully Mama Margaret would also ease up the burden of ICU for pediatric patients. So that's how the hospital is addressing. But the issue of always saying there's no bed, we are putting systems in place so that we try as much as possible to give beds. But I agree with you, that challenge is actually there. I can see people, I don't know if they can be unmuted because I don't see any other question on the Q&A. Wanda, Emmanuel, if you can kindly unmute. And if Dr. Sirius is around, please put Dr. Sirius as a panelist because he's part of the committee. And Manuel. So Mildred, kindly unmute yourself. You've been given an opportunity to speak. Dr. Ayako of Mildred is speaking. Yes, Mildred Amundi, how are you? Mildred, I can't hear you. You're whispering. Okay,
sorry,
John.
I had no question.
Oh, okay. Sorry, you had raised your hand, so it's fine. John. John, Christine, Paul, Dr. Ayako, you can unmute yourself, and Kirira, if you had a question, unless you accidentally raised your hand. Okay, I'm just waiting for Dr. Syriac to join in. If you have any, let me look at the chats, because the chats sometimes are just... Dr. Syriac, do you have any addition, subtraction from what I said? How are you, Dr. Dr. Syriac is our pediatric nephrologist in the hospital, who has been very instrumental in ensuring we have a good referral system for especially the pediatrics group. Over to you, Dr. Dr.
Good afternoon, Dr.
Good afternoon. Good afternoon. Nice to see you.
Thank you so much. Yeah, me too.
Mm.
Yeah, so from the first now time we initiated now this program for the outreach in several hospitals, we really found what is underlying problem in each facilities, and we try now to create the channels where the doctors and the nurses on call they can contact the Kenyatta National Hospital for better referrals. And that really has helped in terms to reduce the number of the patient admitted at the Kenyatta National Hospital. And at the same times, also the referral has been in the right channels, because you found, for example, some patients have been referred for cardiologist review on Saturday, on Sunday, but most of the hospital we visited them says, if the child needs to be seen or another patient needs to be seen by a cardiologist, it's better to send that patient at the day of the clinic. So as you showed them, for example, for the infertilities, it will be better to refer the patient on Monday, where specifically the consultant will be available and the person will be seen by the right doctors at the right times. So we did a good job. We saw almost 6 or 7 hospitals. We still have a long journey, but the communication is okay with the knowledge. And we are standing as the good team. We are trying to visit again, and we communicate by e-medicine, as you saw in Isiolo counties. Also, I remember there's one patient I managed as I think it was Isiolo or Wajir, when we are communicating through e-medicine. So it can be possible for some patients who don't need a direct review by the consultant, and it can give the result reducing the number of the congestion in Kenyatta National Hospital, but also reduce the loss, let's I said, the loss of the money for the family, because if the patient can be managed nearly so at home, it will be better, and also it increases the knowledge in this case for the doctors, because you have a direct contact with the treating doctors, you give them directions, give them which samples supposed to be taken. So once they are available, you try to analyze to get their result. And we found it can be work, and we have hope probably it will improve by times. Maybe one of the challenges is availability for the ICU bed, because most of the hospital call for the ICU bed, and we don't have enough capacities. And in our progression, as you said, we want to open now the other hospital like Mombasa, Kisii, to have other capacities probably will improve. Yeah, thank you so much, Doc.
Thank you very much. And maybe just to add, of ICU bed, we have an ICU like a guideline policy on prioritizing who would benefit from ICU, because one of the biggest challenges would have, I think one of the longest people we've had in ICU is 3 years, 4 years, whereby somebody who clearly would never benefit from ICU is intubated without, like proper assessment prior to it. So there are those cases like, for instance, DKA, who we really try to make a bed available for them because they have a high turnover and do not lock the bed to that specific patient. And if we could have, if we adopt the same policy everywhere, and also early referrals, I strongly believe the earlier you refer somebody, the better it is. We don't have to wait until the tail end for such things to happen, especially in cancer patients. We can work on a framework whereby the samples are sent from those counties to Kenyatta National Hospital. We offer histology at a very subsidized rate. The other day we actually did it for 1,400. So yes, we have these services available. We can have a framework, and you can actually write if you want an involvement with the hospital to UHC at knh.or.ke. I will write it on the post for that specific agenda. So without, in case, I don't think I've seen any other new question. Somebody has asked, where do you refer elective referrals so that they know the right venue for clinic? Do you send them to A&D? No, we do not send them to A&D. What we want is for them to go straight to the clinics. And that's why I'm saying I will make sure, I'm tasking myself to make sure we update the clinic schedules on our website so that the people can know when this specific clinic is for them to come. But however, like I mentioned earlier on, there's some specific specialties that their clinics are ongoing, one of them being cancer treatment center, another one being ENT, ophthalmology. They always have somebody to do the filtering. So there are those clinics that you have that advantage. But for patients who have emergencies are the ones who are supposed to go directly to A&D or PEU or labor ward. I hope I am clear there. Thank you for KNH for making referral structures. If referrals are allowed from one issue to another, like yes, we do not have any issues with referrals from one national to another. We are also advocating for downward referral if a patient has benefited from a specialty care and they can be followed up continuously from somewhere closer to home, because we understand that sometimes it's easier when you have people who can visit you and your loved ones from nearby hospital. We do have such structures whereby we send patients to other facilities, level 5, level 4, and even MPRH. So I believe, I don't know if Dr. Robai has joined back in and is able to speak.
Yes, Amina, I am back on the call.
Okay, thank
Anything
you.
that you would want me to clarify?
I don't know unless you have any other input, because I think I addressed most of the questions while you're away.
Okay, thank you.
Any input from you?
I don't have any input unless I go through the questions, but you have said you've answered all the questions. There's no need of me repeating.
Okay.
Thank you.
Thank you. So we have come to today's session, but I hope we don't stop there. I hope
Maybe,
yeah,
excuse me, Dr. Amina.
Continue.
I don't know if you mentioned the importance of the referring hospitals calling before referring patients to Kenyatta National Hospital.
No,
because at times we need to prepare to receive. Yeah. So before patients are referred to Kenyatta, we normally expect that a call is made, so that we expect that we are getting patients from a certain health facility, so that we can be able to prepare to receive the patient, other than the patients just coming to Kenyatta, and probably we don't have, for example, ventilators. All our ventilators are full, so we need to prepare in advance before we can receive these patients. So I would urge all the referring facilities to be calling us so that to prepare in advance. Thank you, Alina.
Thank you, Daktari. So in summary, we understand the challenges that people face when referring patients, and it's because of really a lack of communication. And for us to start this series, mentorship and capacity building, for example, and we're trying to make our referral to have a community, especially like I mentioned earlier with public hospitals. Like for example, the pediatric surgical team, they normally, this year they've had their third annual workshop, ARM workshop, anorectal workshop, whereby they invite like 7 to 10 county members who have pediatric surgeons, for them to come to do this highly specialized surgery, and for them to brainstorm with each other, share information with each other, and hopefully also peer-to-peer reviews. And that's the vision we are having, for us to have better collaboration, especially as public hospitals, and even our private counterparts. So we hope this community would build. We are welcoming any suggestions. We are welcoming any comments. And I'm sorry for the background noise. I'm not sure where it's coming from, but I thank you very much for listening in. And please reach out through the emails. I am writing the UHC email, but I actually have access to both, so you can write, and we have better discussion.